It's my happy duty to introduce Liz Sampson. Now, Liz is really an old friend. I won't embarrass either of us by saying how far back we go. We go back quite a long way from being young and callow fellows in the under the guidance of Martin Rosser in the Dementia Research Centre many years ago. But Liz has built an illustrious career as a consultant psychiatrist and now reader in psychiatry in the Division of Psychiatry at UCL. And the topic she's talking to us about today is one that actually we've been very interested in at the Dementia Research Centre as well, from a research perspective, which is around how people with FTD process pain and how we might manage it. But I think Liz will be giving more of a clinical talk. Thank you. Over to you, Liz.
Thank you. For a small fee, I will tell you some of the things that we enjoyed as research fellows about 20 years ago after my talk. Thank you very much for asking me today. I have a slightly unusual career trajectory. So I started off doing my MD in FTD, MND with the DRC, and then I moved into more clinically applied research, and I still practice clinically. I'm the lead person for older people's liaison psychiatry at North Middlesex Hospital, which is a very big acute trust up on the North Circular, and that very much keeps my feet on the ground. And I'm the lead there for dementia and delirium. So we do see a few people with FTD every year in the hospital. And then with my other hat on, my research has really developed to be quite applied, and it thinks about palliative and end-of-life care for people with dementia. So this has been a really interesting field, because when we say that, people immediately think that we're thinking about that very end stage of life. But the model that we work to is that a palliative care approach is really a needs-based approach, and that once people get to the more moderate to severe stages of dementia and the focus becomes on their quality and not their quantity of life, that is our very broad definition of a palliative care approach, where we're not necessarily thinking about how long someone has, but about how we can best meet their needs as they move towards the more advanced stages. And we do a lot of work on symptom problems that people have in the more advanced stages of dementia. One of the key symptoms that we focus on is pain. And I'm very fortunate, because you'll see the Marie Curie logo there, and most of you will know and think of Marie Curie as a cancer end-of-life care charity. But about 10 years ago, they realised that the numbers of people dying with cancer were going down, and the numbers of people with dementia were dying with dementia were going up. And interestingly, certainly in the over 75 age group, dementia is now the leading cause of death in the UK. So they had great foresight in supporting my post and my research. So I can only do a very brief overview today, really just to start the discussion and let you know where we are with research in this area. There's a fair amount of research about pain in people with dementia, the older population, but there's very little research about pain in people with young onset dementias and the more atypical dementias like FTD and FTD-MND. So I'm just going to talk about what we mean by pain, causes of pain, how we can pick up pain in people who may not be able to communicate this to us, managing pain, and then hopefully some optimistic news on future directions that we're going to take. And hopefully there will be some time for some questions and discussion at the end. So it seems a very simple question when we think, what is pain? What do we mean by pain? But actually, pain means different things to different people. So this is called the Lerser pain model, which is the one that's mainly used in clinical practice and research. And traditionally, we all think of pain as what scientists and researchers call nociceptive pain. And all nociceptive pain means is that we have a stimulus on our body somewhere that indicates potential harm to our tissues, and that causes a pathway up to our brain, and our brain says, yes, I'm in pain. So that's why we've got our drawing pin there, because that's our classic picture of pain. So that stimulus causes pain, but over that it causes suffering as well, and that can be pain in itself. And then that suffering leads us to change our behaviour. And it's very important to understand this kind of hierarchical concept in people with dementia, that it's not just about the thing, the drawing pin, causing the stimulus and causing the pain. It's about all the other things that are then consequent on the pain after that. And within this, we also have this very interesting concept of discomfort. So someone who is in pain is inevitably in discomfort. But we know that for people with dementia, they can be in discomfort, they can be cold, needing to go to the toilet, hot, hungry, and that can cause discomfort and also can make them feel very uncomfortable, but it may not be the same as pain. And we're doing some work to really try and distinguish those two things in people who can't communicate, because if someone's in pain, we need to give a painkiller. If someone's in discomfort, we need to attend to that discomfort. So you can see that it's already quite complicated when we try and unpick what's going on. But there's a really good practical definition of pain, which we use in pain research, and that's that pain is whatever the experiencing person says it is. So the gold standard for all pain research, actually, whether you're doing a drug trial for arthritis, anything, the gold standard is self-report. If a person says they are in pain, then they are in pain. But obviously that has difficulties where people are unable to communicate. It's a very useful model for us to think about. And there are particular issues in young onset dementia that we are aware of and that we know cause difficulties when we're thinking about pain. So first of all, we know the struggle that some people have to get a diagnosis. So some people may be in pain, they may be unable to express that, and they may still be going through that diagnostic phase. We know that sometimes young onset dementias can progress in an atypical way, and that can affect how pain is registered. And we also know that people with young onset dementias, and particularly FTD and FTD MND, can develop more neurological symptoms and problems like having fits. They might have problems regulating their breathing regularly, but the key one for us is that they might have difficulty swallowing, which can make it difficult for people to take painkillers and for us to manage the pain that they have. Also, pain is a kind of social and cultural construct as well. And when we have people, older people with dementia and they're in pain, it's something that families often recognise because they see an older person, they're frail, they may have arthritis. When someone has a younger onset dementia, the whole family structure is different. There may be young children at home. And so people might not actually think, well, this person's in pain, because they don't meet that stereotype of the frail older person with arthritis who are experiencing pain. So that's what we call age incongruence. So as you all are so aware, when someone has a young onset dementia, it's happening at the wrong age, and that can make detecting and managing pain more complicated. Because health professionals might not pick up on it. Most health professionals will never see a case of young onset dementia in their careers, and that can make it very challenging. The other thing is that we all have an individual response to pain. And you will all be aware of this in your own families, and that's really, really important. So some people, when they're in pain, they like to walk around, make a fuss, wail. I'm not going to make any gender stereotypes here, honestly. But other people, when they have pain, want to just go away, hide themselves, keep still. We all have an individual response to pain. But what we know is that can change quite profoundly in people with dementia, especially in people with frontotemporal dementias or frontotemporal dementia with motor neurone disease. And that's because of very complex changes in the brain. So people may lose awareness of different parts of their body. And I think that's quite a difficult concept for us to get our heads around, but they may not actually know this is an arm, and this is what arms do, and this is my arm, and this is where my arm is. So if they're feeling pain, it's very difficult for their brain to pinpoint where that pain actually is in the body. Also, there are changes in how people process emotions and how they show their emotions. So someone with FTD or FTD-MND who's in pain may laugh. We've had histories of that when they're in pain. They have a different emotional response, or they might become very, very distressed but be unable to say what's distressing them. There are also some studies that that indicate there may be changes in the pain threshold and that people experience a different amount of pain before they report it. And that's a tricky one because we don't want to say that people with FTD or FTD-MND can kind of manage more pain, because we don't think they can, but the kind of threshold for feeling that pain changes and goes up. And that can be a bit dangerous if something is damaging them or causing them pain and it's not registering in the same way in the brain. And also some specific work that Jason and his team have done show that in specific mutations that cause some really rare causes of FTD, people with those types of FTD actually feel pain and temperature in a different way. So it's a very, very complex picture. And then kind of overwhelming all of that, and many of you will be aware of the language difficulties that people have when they develop frontotemporal dementias or rare dementias. And that's a really profound problem in how we communicate to people and how people communicate to us. So the classic example I'll get is that if you go into hospital and you think you might be having a heart attack, then the junior doctor, who is not very experienced in these things, will quite likely say to you, "Are you having central crushing chest pain which radiates down your left arm?" Yeah? And that's a standard medical way of asking about things. And for you or I, that's probably fine. But if someone has frontotemporal dementia, just that simple question, there are multiple layers of confusion. What's my left arm? What do you mean by central? What do you mean by crushing? And also, how do I tell you where it is? So we have to change our language as well in terms of asking about pain, and I'll come to that a bit later. The other really, really interesting concept, which is quite difficult to understand, and even as a researcher I found this very difficult to understand, is that some of you will know that in frontotemporal dementia and dementias that can affect the temporal lobe in particular, we lose what's called semantic knowledge. And that's our very deep underlying, underpinning knowledge. And there is some evidence that people with those forms of dementia lose the knowledge for what pain is. So they may experience very deeply distressing symptoms, but they may not actually know that that is pain anymore. It's quite a concept to get your head around. And I'll just illustrate this. This is a very simple study that we did a few years ago, where we did this actually in people with Alzheimer's disease, but I think it would be something really fascinating to do in people with FTD. So we made this test with a team in the Netherlands for the semantic memory of pain. And what we wanted to try and understand and unpick is when someone's semantic knowledge for pain goes, when they don't know what pain is anymore, they may not be able to tell which of these pictures are actually painful things. So we had these pictures of potentially painful things. So everyone has the worst one. My one is the car door. To me, that's the one that really sets me off. Not very nice. And then what we did is we scattered them with very, very similar pictures where there isn't potential pain. So you'll see the car door being opened properly and trapping the fingers. And we showed that to people in various stages of Alzheimer's disease. And what we found was very interesting, because we didn't ask them to talk about them, we just wanted them to point to the painful ones, point to the one that hurts. And as their Alzheimer's disease got worse and worse, they found it harder to point to the pictures which were painful. And I suspect that if we did this study in people with FTD, we might find that even in the very, very early stages, people are struggling to identify what that pain is. So this comes to the interesting question, how do you show you're in pain if you don't know what pain is anymore? And this is where we come to sort of the more practical aspects, and many of you will be aware of these from your own experiences. So people might not be able to communicate that they're in pain, and so we have to use different words and gestures. So in my clinical practice, I will say, does it hurt? Is it sore? Does it ache? And instead of asking people to point to me, I will point to them, and I will literally work top to toe down the whole body. Is it here? Is it here? Is it here? Is it here? So how we communicate, and we use visual cues as well as verbal cues to try and unpick whether someone's in pain or not. So using different words or gestures. A really useful rule of thumb when someone has dementia and they're having trouble communicating for anything is see change, think pain. So if there's a sudden change in how someone is behaving, if they become more unsettled, if they become tearful or they become distressed, then that could be an indicator that they're in pain. And all of these things can be indicators of pain. People can be agitated, they can be more withdrawn, they can be holding themselves stiff because they don't want to move, they can go off their food, they can not want personal care to be washed or dressed or changed. Sometimes they get repetitive movements, they might start pacing or scratching a part of their body. So all of those can be pain indicators. And what's really important that we pick up on these, because if not, we get into this very, very sort of vicious cycle that I'm sure some of you may have been trapped in, where people with dementia become in pain and discomfort. They get then distressed behaviours, which are completely understandable. Their behaviour changes, they become distressed. They're trying to communicate. But what can happen, especially in care settings like acute hospital wards, is that then others disengage and the staff and everyone else takes a step back. And then the person with dementia loses personhood. They're not seen as an individual person because people don't want to engage with them. The attention to person-centred care deteriorates, and then the pain and discomfort gets worse. So we have to find ways of interrupting this kind of downward spiral and circle. So we can give painkillers for the distress behaviours for pain and discomfort. We can use things like "this is me" or 10 things about me to give the personhood back to the person so that staff see them as an individual, and then they start unpicking the pain. So it's really important that we try and get to the bottom of pain. The other thing that tends to get lost is that someone with frontotemporal dementia and MND or any form of dementia can still have the same pain that we all have. So people tend to forget that someone with dementia can have a migraine, they can have a toothache, they can have a heart attack. And so one of the really important things, and I'm sure you've all done this repeatedly in your journey through these experiences, is that you have to be an advocate for that person. And some of you might have to push very, very hard and keep saying to the health professionals involved, I think they're in pain, I think they're in pain. It's something that we have to do in clinical practice all the time, is to try and really push and advocate for the person. Another thing that we know is that we don't use different methods. So in people with dementia who are in pain, we tend to just think, well, we'll give them some medicine. But actually, if you or I sprain our ankle, we'll use warmth or heat or massage or frozen peas or all of those methods. And those methods tend to get forgotten in people with dementia. So we tend to forget that simple kind of comforting stage. And medication is really, really important and can make a huge difference. So studies have shown in people with dementia residing in nursing homes that when people are given regular paracetamol, the agitation levels in the nursing home go down, because what that's doing is treating undermanaged pain. And just very quickly, when we're thinking about pain medication, and I give you this because I know that professionals from the studies that we've done get very, very stuck on just giving paracetamol. And what they do, and I think we've all probably been guilty of this, is that they also tend to just give paracetamol as required, so what's sometimes called PRN. And the most important thing to remember for someone with dementia is that you give regular paracetamol, because they're not going to remember that they've been in pain, they're not going to ask for paracetamol. So one of the really key interventions we find most useful is the simple act of prescribing any painkiller regularly. And then what the other problem we have is that people get stuck on the paracetamol and the ibuprofen, but actually, this is what we call the pain ladder. There are a whole range of pain medications that we can work our way through. And some medications, like the weak opioids, such as codeine, they can be bought over the counter. Now, there are side effects to these medications. They can cause constipation, they can cause confusion, but sometimes a small nudge to the healthcare professional to say, can we try something a bit stronger, is really important. And also we need to think about different types of pain. So paracetamol is a really good regular painkiller, but actually, if you have a toothache, you need what we call a non-steroidal anti-inflammatory drug, so something like ibuprofen. Ibuprofen is much more effective for toothache. So in our day-to-day practice, often we're just giving the nudge to the other doctors or the GPs who are prescribing, saying, can we try something regular? Can we try a different painkiller? And occasionally, rarely, we have to move up to the morphines and the strong drugs. The other thing that people tend to forget is that you don't just have to take painkillers by mouth. So some stronger painkillers are available as patches. If someone's got very severe dementia and they're being turned and cleaned and having personal care on a regular basis, sometimes rectal paracetamol can be incredibly useful. It's not something that's in our culture, unlike other European countries, but actually it's very, very useful. Often people won't even notice that's being given. It's very quickly absorbed, and you don't have to be able to swallow, because we know that some people are going to have swallowing difficulties, particularly with the other forms of FTD. And also preparations, so liquid preparations, lollipops, patches. There's a whole range of things out there that can be used once the once the expert help's there. And if you've got a good GP, they will know this. If GPs aren't so confident about pain and dementia, then they can sometimes need a little bit of a nudge in that direction. And just to say that it's really important because we know that pain has a huge impact on carers and families. So carer anxiety and depression has been shown to increase when the person with dementia is in pain, and the health rating of carers goes down when the person they're looking for is in pain. So that's why it's another really important reason to think about pain, because it affects everyone's well-being. And just finally, when we're thinking about palliative care approach, we like to think about total pain. So not just the physical pain. Is there other distress happening here? Is the person socially isolated? Are they depressed? Are their spiritual needs not being missed? We would try and encourage a holistic approach, which is really just good person-centred dementia care. But it's really important to bear that in mind, and that's the approach we take in palliative care. So just to finish, future directions, we've got some really interesting research going on at the moment. We've been looking at simple, what we call heuristics. Heuristics are just simple rules of thumbs. Healthcare professionals are very busy. They lack confidence. Some of you will be aware of the Howard Shipman affair. They are very, very, very frightened still of prescribing painkillers adequately, particularly to frail older people. So Nathan Davis, who's one of my research fellows, is working on these deceptively simple heuristics. They're just basic rules of thumb for healthcare professionals. They can use quickly in clinical settings to guide decision making, and it pushes people down particular routes like, have you thought of pain? And a really interesting project that we've just got starting is the use of a phone app for facial recognition of pain as well. So everyone changes their facial recognition, their facial expression when they're in pain, similar technology to what you use when you're going through passport control. But this app has been tested and is shown to be very effective in picking up signs of pain in people with dementia. And we're going to be doing the first trials in UK acute hospitals and hopefully be adding it to other studies with people with FTD as well. So things are moving along. We've been very fortunate. We've recently been funded a very large programme grant. It's the largest programme grant to improve end-of-life care for people with dementia in the UK, working with King's College and various colleagues across UCL, developing interventions to improve the last year of life for people with dementia. But I just wanted to draw your attention to the WS just stands for work streams. It's just research speak. But we're going to be doing some studies about pain and symptoms in people with dementia, looking at what their palliative care needs are. And we're very excited. We're going to have a PhD student looking at pain and symptom burden in people with FTD. And that will be one of the first studies of this kind. And that will be really interesting. Similar work going on with the prion unit as well. And, you know, it's delightful to be working back with Jason and the team back there. And that will really help us drive forward research in pain management clinically in this area. So that's a very, very quick whiz through the topic. Thank you very much for your time. Thank you. Yeah.
Regarding pain, particularly people with FTD, at home they can be very uncooperative. And in care homes, from what I've seen up and down the country, a typical cause is cleaning teeth, brushing teeth, and so on. Do you know of any other drink that you can give them, or is there any other way that you can protect the gums and the teeth and the resulting pain other than using the brushing technique that we all know about? When
I don't have a lot of experience in that area. We do actually have a dental student from the dental school in Amsterdam who's doing her PhD with us at the moment, who's looking at oral care in people with dementia and ways to improve oral care. Someone's got their hand up there. They might have the answer to this.
I'm a speech and language therapist who specialises in oral care in people with dementia. And there has just been a CQC report published on the 20th of June. I don't know if you've seen it, but looking at oral care management in care homes and how it is and has been really quite badly neglected, and why people have such oral care distress, oral health distress, is because carers are afraid of carrying out oral care. And there's an awful lot of work going on throughout the country, certainly in the south, and I'm a part of it, to try and carry out projects and get things going for giving carers training and support to manage oral care more effectively, both in care homes, and then we will take that out beyond that. So a lot of work going on at that. NICE published a document in 2017 which gives advice on oral care management. It can be very tricky because oral care is such a personal thing, and when you carry out oral care, you're right in the face of the person that you're working with, and people find that intimidating and just too much. You need to both be sitting down, and the person needs to be at face level. And I think showing somebody what you're going to do on yourself, and then very gently doing it. But if you have somebody who is aggressive, you will need two people. You will need one who will distract and the other one who does it. But we are always saying to people, it is not something you can neglect. Carers often say to us they would rather clean a bottom than clean a mouth. And, it's complicated, it's challenging.
Well, can I just say the oral hygienist who looked at my husband's gums, which are receding because he'd been over-brushing with an electric toothbrush, which we've all been encouraged to use over the years and everything else, they told us to switch to a children's soft toothbrush, and if necessary, use really sort of, fruity, these awful toothpastes I consider, just because then, he's not going to do any harm, but it's just regular, and it's happy he uses a soft toothbrush now. Now, obviously, he's not maybe as extreme, but he enjoys just the soft brush in his mouth, and it's not stripping his gums, which is his other toothbrush was. Yes, but with a soft toothbrush, he's not. They've said that it's just the regular movement rather than how abrasive you are, and he was being too abrasive in his mouth because he quite enjoyed, I think, the sensation of 3 or 4 minutes. Yeah, but soft toothbrush anyway.
Yeah, are we on? Yep. I think it's very relevant, and the teeth thing is actually quite interesting because my wife is in exactly that particular case. So we go to the dentist regularly and we go to the hygienist, so we take care of that. We have an electric toothbrush. But I think, believe it or not, I saw something on YouTube where actually you stand right behind the person and just to, like, say, the right of their head, and you have the brush and you put their hand on your hand. And so they're actually part of the process. So what we try to do, and just like the lady at the back, my wife's gums are going at the top at the back because the top sits actually because bottom ones are easier to clean. And by doing this, she tries to pull it away, of course, because it's sore, but if you stand behind them and put their hand on top of yours, so they're actually working with you. Interesting.
Thank you very much. Yep. Just in the middle there. There's a mic coming, so sorry.
It's a change of subject. My husband is prescribed Oramorph. He can't communicate. We don't know about the pain. So it was very interesting to hear about paracetamol. And we don't know if he's in pain, it's very, very difficult. Mm-hmm. And I was surprised you say about laughing, but his change of facial movement. And is the paracetamol will be a good idea to give as every day, or with the Oramorph, or?
No, I think once someone's on Oramorph, that's probably the best thing for them, and we wouldn't recommend giving paracetamol as well. Mm-hmm. Paracetamol is a milder painkiller. Oramorph is stronger, and giving the two together wouldn't really make a lot of difference. So we would normally say if you're on one, that's our ladder. That's kind of the third step. Then just stay with that because it relieves feelings of distress as well, and it can be very effective.
Because he's in bed 24 hours. He's completely blocked on one side like that. We can't. So I think and I don't know what we give him as a Oramorph. We increased the dose, and after he was showing agitation, so we decreased the dose. But I am not sure he's got enough. So it's very difficult, and nurse and doctor are really, it's very difficult for them to...
Yes.
To,
I guess it's
so
if you...
a very,
It's if you see that change again, isn't it? And it sounds like you saw some agitation, you increase the dose, it's settled down. That's all we can do really, is just look at the person, look for any subtle changes. And
because I always very often think is in pain, but you know, what you do, it's just, it was quite interesting. Your facial things, I really like to see that.
Yes.
Because this is something you don't know what you mean. It's just so difficult. Yeah.
One of the problems is, of course, facial expressions change and it may not be reliable in FTD. It's a very big, complicated problem. There's a question here. Sorry, sir.
I was following up that, actually. Yeah. It's just that it's worth knowing, it wouldn't be relevant to the Oromorph, but that my wife is on regular ibuprofen, which I arrived at because she had some arthritic pain. That's controlled it nicely. But it's worth remembering that you can add paracetamol to ibuprofen, and they are actually synergistic because they have different mechanisms. So you don't have to necessarily progress to the second stage. It's a simpler way of getting pain relief at a relatively low-risk cost.
I think, unfortunately, we may have to... I know there are lots of questions. One more. One more. Sorry.
I just wanted to know how we could get involved. We've had several, and I mean several, serious problems with my brother and pain. You know, he cut open his leg. He got badly stung. And because he didn't know he was stung, he carried on digging and digging and digging this wasp's nest, and he got stung about 15 times because he doesn't relate. How could we get involved? You say you're doing research into it because he definitely has a problem with pain with FTD. Could we get involved?
We're setting up our study at the moment. We have got a mailing list, and I can give you our mailing list email, and then you'll receive regular updates about the studies and opportunities that are coming up. It's a 5-year project we're just setting up at the moment.
So this is the honcho, the key person, but we are collaborating, so it'll be very interested though to start to, particularly people who've had very striking problems, of course, with pain, because they're likely to teach us about a lot of that. So I'm going to have to draw that to a close. I'm really sorry. And thank you, Liz, again. Thank you so much. Wanted to hand over, though, to give Judy a bit of a chance to have a chat about experience of rare dementia support. So, Judy, welcome. Over to you. And hopefully there will be a chance to pick up on other questions both at lunchtime, but also at the Q&A that we'll do this afternoon.
Good morning. Can you hear me? Good. I don't like talking from notes, but it seemed entirely reasonable that I had to present bullet points for what I was going to say, so I shall be. I think I'm probably speaking most of all to those of you who've come for the first time. I found that when my husband was first ill, everybody, health professionals, were very careful not to upset him. But everybody could tell me what to do and how I was doing everything wrong. And one of the things that I was persuaded to do, very much against my better judgment, was to join a care group. And the local ones, it depends who your neighbours are. But this one I found absolutely invaluable. And if you've come for the first time, I'm not asking for a show of hands or anything so humiliating, but you'll know whether you came willingly or because you felt you ought to. The great advantage of coming to a group like this is that there are no taboos. A lot of people will be more experienced than you with how to deal with whoever it is they're looking after. And one of the things that I think is important is that carers have a life. And these meetings are frequent enough for you to make friends, well, to get to know people, but not so often as to be tedious or invasive. The most important thing that I learnt here was to deal with everybody else particularly people who told me not to feel guilty, as though somehow it might be my fault that my husband was ill. I think the other things that by general discussion here, this awful business of embarrassment. So before we moved house in Hammersmith, and we tried a day centre with my husband, I was told that on no account was I to send my husband out when he had an upset stomach and he had soiled himself. Actually, that was one of the many manifestations of his dementia. It was not important, so it took me a little while to learn that actually he was entirely incontinent, and it had to be not embarrassing. So I would urge you all to develop complete lack of embarrassment about anything. Talk about it. Other people talk about things that you might find boring, so you can talk about whatever it is that's upsetting you. Dementia is not shameful. It's no more shameful than my needing a stick to walk with. And all of dementia is not Alzheimer's. We have the most wonderful GP. When we moved house, he had to fill in a lot of forms so that we could get council help for one thing and another. And on that form, he put that the cause was senile dementia. And I was very forthright. And I handed him the card that this group produces with an online course that GPs can take. As I say, our GP is absolutely amazing, and he did it. And with a bit of luck, you've also got an intelligent GP who knows that he doesn't know anything. I understand that dementia is beginning to creep into medical colleges. Is that the case? But most GPs who are in their 50s won't have had anything as a student. So as part of the things that carers can do to have a life is to invite people home who've got dementia, their spouse hasn't, and you have no embarrassment. Those terrible table manners are impossible in a restaurant, but it doesn't matter if it's in your home, because it's your partner who is going to be just as disgusting, or more so in my case certainly, as everybody else. Take advantage of what is on offer and proselytize. I have found it's very useful. You tell somebody that your husband, well, my husband has dementia, and people would say, oh yes, how's the Alzheimer's going? Ask about what kind of dementia. I think those of us who know have a responsibility to the rest of the world to draw attention to the fact that dementia is not a one-off diagnosis. And the other thing that I think we all need to work hard on, and I would love to have advice as to how to do it, is to try to get all sorts of dementia seen as an illness. We were enormously lucky. My husband had the good sense to get cancer, and that's what he died of. So he went into a hospice. We were told that he probably had many, many months to live, and so he was moved out of the hospice. But it was the hospice and the doctors there who arranged for him to have continuing care, so that you have got a National Health Service provision for what's going on. His cancer actually didn't make him ill. That sounds an awfully stupid thing to say. Had he not had dementia, it would have been much easier to manage all of that. But at least we didn't have a huge financial worry as to how he was going to manage and how we were going to manage. So, just to end, I'm very happy to take any questions. and put yourselves in the middle of the problem. Because as carers, if you're not coping with yourself, I don't think you can cope with anything else. And that really is all I have to say. Keep coming.
Dementias. My husband's got FTD and he's 56. It seems to have slowed right up, and well, not slowed right up, but the things that are going wrong are only minor little things, and the family and friends, they're non-existent. They've all walked away. They all think it's me saying there's something wrong with him, and that's what I'm really, really struggling with. I don't blame myself for having any guilt, but I lay in bed of a night wondering that if he hasn't got FTD, how am I going to live with myself? But it's the family and friends that have just all walked away is my biggest concern.
May I reply? I found that people also walked away, partly because Patrick was so disgusting, partly it had not been a very good marriage anyhow. I'm not for a moment suggesting that's your case. But I think that if you bring it up as a topic, I mean, 50 is terribly young, but clearly there are going to be odd behaviours. Just draw attention to it. Don't pretend it's not happening. Say, I'm sorry about this. That is how we live now. So please do keep coming, but put up with us. When I moved house, I misjudged it dreadfully. My husband was sitting in the entrance foyer of the new block that we were moving to, and he didn't speak. And of course, a woman came in and he didn't get up. And somebody looked at me, and I introduced myself, and I said, and this is my husband, we'll be moving in next month. I'm sorry that, please don't worry about his behavior. He's got dementia. And she went, oh, and I say, well, it's not infectious, and he isn't going to run round the block in the middle of the night ringing bells. Now, I shouldn't have said this because it gave her the idea that he might. He didn't. So I think if you are more upbeat about it, certainly I was told to go to marriage guidance when all this first started. Has that been suggested to you? Yes. Well, tell the doctor and tell your friends that this has been suggested and it's nonsense, because that's not what the problem is.
Can I just say from a health professional point of view, this is a very, very, very common history. And the spouse often starts to begin to distrust their own sanity because they are subject to a continual barrage, and it can be very isolating. So, for example, and this is one of the things I hope this group will be useful for, that you begin to see you're actually not alone. And I've had one lady that came along who said in the clinic, sat in the clinic and said, I'm now known as the witch of the village where they live because of this idea that I'm persecuting my husband. And he had FTD, unequivocally. So, I mean, it can be a very, very nightmare situation, not only because of living with the illness, but also because of what it does to people. And partly that's fear and incomprehension, of course. That's the charitable explanation for some of the reactions. People do not understand this at any level. And of course, what people don't understand, they usually either frightened about or they can be very unsympathetic about, because they just don't get it.
This is not so much a question as a bit of information. We belong to an elderly group where a gentleman from BBC came and he was filming various people with dementia in our group. And he interviewed myself and my wife. And that program was shown either in February or March on Victoria, Derbyshire, What My Dad's Dementia Taught Me. That's the title of the thing. The other thing is there are groups who do filming of my life for people with dementia, and that is worth trying out. This is with a view to spreading the knowledge and trying to remove the stigma. Thank you.
I just wanted to say that I resonate with what you said at the end. If you don't take care of yourself, you can't take care of anybody. You can't take care of anything else. But I wanted to support this lady's comment to say that I use social media and I try to use it for positive benefits. And for example, my husband is 48. He was diagnosed 2 years ago, but he's under Professor Warren's care now. I struggled with having friends and family support me. And basically, I put it out there on Facebook and I said, look, my husband's going through some times of changes. If anybody's willing to come, I'd really appreciate your help because I can't do it on my own. And actually, the whole of the church came and supported me. And then I set up a WhatsApp group for my family and I updated them with the updates that I got from when I visited Professor Warren on Monday. So that's what I did.
I know I've said this to a lot of people before, but I'm an ambassador for Dementia Carers Count. And until the end of 2019, they will still be running free 3-day residential courses in Edgbaston. I've put leaflets at the back, which I really strongly recommend anyone who's struggling to try and find somebody to look after the person that they care for so that you can go on a course to help you, teach you resilience and look after yourself as well as the person you're looking after. They also do one-day courses, which you have to pay for, but you do get lunch for that. But there are leaflets at the back, and I'm happy to talk to anybody about. It's a charity, it's free for this year, and there is a special course in November for young onset dementia, which I can't strongly recommend. Get yourselves on that course because it's not going to cost you other than a train ticket to Edgbaston.
Can I just endorse? I know there are questions, so I don't want to take up too much time. But just it is absolutely so from a health again. It is absolutely critical, and particularly I'm thinking about people that might be earlier in the process, in the journey, critical that carers, caregivers, family members look after themselves because you will not be able to look after the person. And if you can't, you're the key, really, unfortunately, to making this work. So that I really can't endorse that comment and some of these other comments that have been made too strongly. Right?
If I could butt in there, all your friends will tell you how selfish you are, but it doesn't matter.
Well, that's a good point, Judy. I mean, you're right, and I enjoyed the talk, and I think a sense of humour is a fantastic thing. In terms of what we're all involved in, my wife, she's doubly incontinent, and I think my 1-year-old grandson eats better than she does. I think I'm going to buy her a spoon and pusher and a bib. And put a great big tarpaulin around the table because that's the only way I'll be able to clean it up all the time. But these are things that we all have to go through. And I think to have a sense of humour is the first thing. And you do understand and you do find out who your friends are. Oh, yes. And yeah, a proportion of them walk away, and some people are absolutely fantastic. And my advice is to grab those people and make sure they continue to be part of your life because they're the people that can help and support you. Because as a carer, you're isolated to that degree, and if you're doing it all day, every day, and whatever you're doing, then you have to find outlets for all that. And people used to say, well, John, for heaven's sake, how on earth are you going to cope with all that? I said, well, how do you hope to cope with that? I said, well, there's two hopes. The first is no hope, and the second is Bob Hope. But there is a huge amount of information out there. I am part of, I live in southwest London, so there's our local Alzheimer's branch has a series of carer meetings which I can go to. There's events that I can take my wife to. She doesn't like any of them, so we don't really go to that many, but that's the way it is. But I think coming to things like this and being able to share some of your experiences and to be able to understand where to go for information. I mean, there's the local council, there's HUK, there's lots of different places you can go to for information. Websites are another very good one, and the rare dementia one I think is just recently upgraded is a very good source of quality information. So there's plenty of help out there. You just got self-help, I think, is hugely important, and an enlightened view, and a sense of humour will never do you wrong.
Very important. Just for the young whippersnappers, Bob Hope is an American comedian.
Hello. I've been through this as well because I was accused of arsenic poisoning by my brother-in-law. And then when the police investigated that, and of course at Queen Square, part of the diagnosis is they test for heavy metals, and he wasn't. He was negative. So then I was accused of my bullying, and my husband was an ex-6-foot rugby-playing consultant surgeon. And then when that didn't work, I got taken to the Court of Protection. And I can tell you, everybody leaves you. My neighbours were going through up the other aisles of Sainsbury's because nobody wants to come near you. We've been through that, and now he has died. He did die of cancer. So I can totally sympathise. One of the things, you'll see there's some cards out there. A friend of mine who was head of anaesthetics at another hospital and stood by me through all of this, has been making cards non-stop for raising funds for the research that they do here for FTD. So please take some, and donations would be welcome. I haven't put prices on them, but I don't want to take them home, and send them out. That gets the message out there. And as regards getting the message out in the world that I've spent years in, UCL gave me their biggest lecture theatre, and I had 200 Crown Court judges and magistrates here, while I trained them all in mental health, diversion and legislation. And we included Jonathan Raw, for a behavioural variant neurologist, as you all know. And so the message got out there. Since, professors have asked me to write a journal paper, which I've done, and the 2 pages was in full. And I've now, believe it or not, had emails from MPs saying to me, what's wrong in this country? What should we be doing? And so I did a very long answer to that question. So I did them a 1-page, which was a summary of this article, the journal paper I wrote for sort of non-professionals, and then 6 points. This is what MPs could do now! ! And this, if they did it, would transform this situation and be cheaper for the country. So if anybody wants that, let me know. And I suggest getting the message out there. Contact your MPs, let them know, and make these changes. And part of it is the whole lack of diagnosis in the first place. That's the key thing, how we address this. And then post-diagnosis, how we get the right care for these people without getting trampled over and all the fighting and emotion you have to go through to get it. That would transform things. So I can send you or give you these 2 papers and the article, and any further support, I'm sure, would help.
I think we're going to have to go to lunch. Can I just thank Judy once more for that great...
Thank you.